Hello everyone. As part of our Saving Lives webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure today to welcome you to our webinar called Challenges in Delivering High-Quality CPR. Is it time for mechanical CPR? And now, I'd like to introduce you to Kimberly Kelly, who is our moderator today. Kimberly is a staff nurse and lead responder at Legacy Emmanuel Medical Center in Portland, Oregon. She has been a very active member in the Association of Critical Care Nurses and is currently a regional board member. In 2015, Kimberly wrote a widely used self-learning module for use in her facility on Code Blue. Kimberly, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
I am. Thank you. Good morning and good afternoon to some of you. Thank you, Emily, for that very kind introduction. The title of today's webinar is Challenges in Delivering High-Quality CPR. Is it time for mechanical CPR? Speaking today on this very timely topic is a colleague and friend of mine, Nicole Kupchik. Nicole has practiced as a critical care nurse for over 20 years. About 15 years ago, she began working at Harborview Medical Center in Seattle, Washington, and this change spurred an interest in resuscitation. Shortly thereafter, Nicole was part of a multidisciplinary team that was one of the first in the United States to implement therapeutic hypothermia after cardiac arrest. As part of this effort, Nicole was responsible for protocol development and has published numerous papers on this topic. In 2013, Nicole founded Nicole Kupchik Consulting and Education. A few disclosures she has I would like to announce. She is on the Speakers Bureau for Physio-Control, La Jolla Pharmaceuticals, and China Medical, as well as being a consultant for Physio-Control and Baxter Healthcare. Continuing education for nurses and respiratory therapists is below. This educational activity is approved for 1 contact hour, and a link to obtain the CE credits will be available at the conclusion of the webinar. The accreditation statements are as below, and support for this educational opportunity and activity are provided by Physio-Control, now part of Stryker. I am going to now at this time turn the presentation over to Nicole. Good morning or good afternoon, Nicole. Are you ready to get started?
I am. Hello, everyone. So it looks like we've got lots of people on the line today. So welcome. And it is morning because I'm in Seattle, Washington, but I know for some of you it's afternoon already. So, but I'm really excited to chat about this topic today. So what we're going to talk about is the use of mechanical CPR. I'm going to talk about challenges around the delivery of high quality or high performance CPR in hospitals and actually EMS agencies as well. Talk about alternatives to manual CPR, which of course would be mechanical CPR, and then talk about the evidence behind the use of mechanical CPR devices. So one of the things I want to start with is just a reminder, because a lot of you have probably been on the line for, I think I've done, this is probably about the 5th or 6th webinar I've done in a series on resuscitation. And so I'm just going to kind of quiz you, just you don't have to say anything or do anything, but about what we've talked about in the past. So in resuscitation, what matters, right? So this is Brittany, I think, pre-head shave in 2009. So, but in resuscitation, what matters? And let's kind of just remind ourselves of what really matters when you think about high performance CPR. So things that matter, and again, according to the guidelines from AHA and ILCOR, the International Liaison Committee on Resuscitation. So chest compressions, the current recommended rate is 100 to 120 a minute. But again, if you've been on my webinar series, you've seen cases where we are just absolute jackhammers on patients' chest. And so we've really got to kind of dial it back and make sure we're getting compressing at the right rate. So not too slow, but definitely not too fast. Depth recommendations are 2 to 2.4 inches. And we've got a lot of challenges, which I'm going to revisit here in just a couple minutes around hitting the right depth. Really minimizing perishock pauses. So defibrillation events lead to huge pauses. And so we've really got to focus on minimizing those pauses and effectively delivering a defibrillation. Don't overventilate. This is a super easy thing to fix, right? This is low-hanging fruit. But a lot of times what we're seeing in codes is people are overventilating, which has a direct impact on CPR quality. So it's going to increase your intrathoracic chest pressure, which is going to decrease venous return and have a direct impact on CPR quality. So again, that's low-hanging fruit. That's stuff you can fix pretty easily. Use capnography. And I'm going to talk about, there was a big kind of write-up yesterday in CNN about a patient waking up during CPR. And actually, I'm going to kind of address some of that. I don't have a specific slide on it, but I definitely want to address this whole idea of patients waking up during CPR during this webinar. So, you know, capnography can be super helpful to verify endotracheal tube placement, CPR quality, return of spontaneous circulation or ROSC, but also it's really helped us guide efforts. You know, do we keep going on a patient or do we stop? And then finally, I'm going to actually revisit medications just for a brief moment this morning because a big study on epinephrine just wrapped up. So I'll talk about that in just a second. So these are the things that matter. So many of you might remember me talking about this whole idea of studying epinephrine. So, you know, again, there was very little research that led to us using epinephrine in humans during cardiac arrest. And so there have been a number of before and after retrospective and observational trials suggesting that possibly epinephrine is harmful in codes. But our current recommendation is 1 milligram every 3 to 5 minutes. And so many of you might remember me talking about this randomized control trial that's happening out of Warwick University in the UK and Wales. And I think it was September of 2014, they started enrolling patients in this pre-hospital study where they're randomizing patients to either get 1 milligram of epi every 3 to 5 minutes or to get placebo. Well, they planned on enrolling 8,000 patients. Guess what, guys? They just finished enrollment. And so this study is called the Paramedic2 Trial, just completed enrollment in February, and hopefully we will have an answer very, very soon. I can't wait to really I'm dying to see the results. I really hope that they separate out the efficacy of epinephrine and VFib versus PEA and asystole, but I'm super excited. So I would say stay tuned. Hopefully we'll have an answer soon as to whether epinephrine is helpful or could it be harmful in some patients. So anyway, I wanted to make sure we updated everybody on that study. So you've heard this phrase before, but poor quality CPR should be considered a preventable harm. And that statement was made by the American Heart Association consensus group that put out two big statements in 2013, one on hospital cardiac arrest and the other on CPR quality. And I really think we need to think about this because CPR is just really difficult to perform either in the pre-hospital or a hospital setting. And so we've talked about what we can do that matters, but I just want to revisit this case just as a reminder of some of the challenges we face, especially in hospitals. But remember, this was a case from a hospital code, and you can see the so first of all, just to kind of orient to this slide, the black that you're seeing here is the underlying ECG rhythm. The green wave that you're seeing is the impedance signal that's coming from the defibrillator pads, and the little blue dots indicate the depth. So we were actually using a device to measure depth in this patient. And unfortunately, they were going at a rate of 141 a minute. So at 141 a minute, they were only hitting about a half-inch depth. And that's one of the major issues with going too fast, is you're not going to hit depth. So the purple lines that I'm about to put up here show where those blue dots should be if we were actually hitting a 2-inch depth. So this is really, really challenging in a lot of resuscitations. If we go too fast, we just don't hit the depth. And it's very commonly seen. But the scary thing was the same hospital started having the nurses, RTs, physicians, code team members use a metronome to guide their CPR rates. And so they would have a metronome that gave them an auditory cue of when to do a compression. So you can see really nicely they were able to get their CPR rates right where they should be. But the really scary thing is, even at the right rate, they were having a challenge hitting depth. And just to revisit, like, why would hitting depth be a challenge? Well, for some people, it just might be body stature. Maybe the CPR provider is, not a very strong or big person, that could be a real issue. If you're not standing on a step stool, if you're 5'8" or shorter, you should be standing on a step stool in a hospital with a bed in the lowest position to provide CPR. But one of the other things that we know is there's a lot of mattress swing. And this animation is demonstrating, when you do CPR, there's a lot of swing in the mattress. And so you've got to overcome all of that mattress swing in the depth, which is very, very challenging. And so, again, a lot of people think, well, what about the CPR backboard? So this is an animation demonstrating with a CPR backboard that there's a lot of mattress swing. So I'm like, okay, these are animations, whatever. So what I did was, I think it was 2 weeks ago, I was at NTI, and I was at the big National Teaching Institute conference in Boston, Massachusetts, and what we did was we set up the mannequin on a bed and put a backboard under the mannequin, and there is a lot of mattress swing, even with a backboard behind the patient's back. And so you've got to overcome all that mattress swing, when you provide CPR. So again, it's just one of the major challenges we face, especially when we're providing compressions on a bed or a stretcher in either a hospital or the pre-hospital setting. So I want you guys to think, so all of you out there, I want you to think in your work setting, when was CPR challenging? So I really want you to kind of think about codes that you've participated in. And when is CPR challenging? And there's lots of situations where it's challenging. So these are just to name a few. Prolonged codes, right? So you've got somebody who you've been resuscitating for a prolonged period of time. Codes in the Cath Lab. So Cath Lab codes can be really challenging because you've got basically the little device that the providers, the cardiologists use to image, that can get in the way, and it's really difficult because the table's so high. It's very difficult to give good quality CPR. In a hospital bed because of all the mattress swing, in a stretcher because of the mattress swing. What if you work in a critical access hospital? Maybe at night you've only got 5 total people working in the whole entire facility. Or maybe your unit is small, or maybe just everyone's tired from doing CPR. Or if you're on an EMS crew, maybe you've only got limited people who can do CPR. Morbidly obese patients, very, very challenging to provide high-quality CPR. For those of you who work in EMS, in the back of a moving ambulance, or if, let's say, you're transporting a patient, going up and down stairs. So there's lots of conditions where CPR can be super challenging. So the question we're asking is it time to think about mechanical CPR in a lot of these situations? And so we're going to take a little dive here and look at some of the evidence in using mechanical CPR. So should we rethink the way we're providing CPR? So Emily is going to launch a polling question. So this is what I want to know. I want to know is your hospital using mechanical CPR devices? So there's a couple different devices on the market, and are you using any of those devices? So it's just a yes, a no, or maybe only certain areas of the hospital. So we'd love to know what you guys are what you guys are doing out there. Okay, so looks like about 15% of you are. Looks like most of you aren't. Okay, so and then only certain areas of the hospital. And I should have really thought broader than that when I made up this question and really thought about EMS as well. One of the things we're seeing is EMS has really started to pick up speed of using mechanical CPR out in the field, and they've really bought into it, but it's been a lot slower to adopt in hospitals, and I'm not really sure the reason of that, but because we've got some really good data to say that mechanical CPR is pretty bad in hospitals, actually. So I don't know, we'll kind of see what the future holds, but maybe we'll follow EMS's lead and start going more toward mechanical CPR. So this is a video, you can find it on YouTube, just of a patient receiving mechanical CPR, and one of the things I wanted to demonstrate is just what it looks like, because a lot of you might be thinking like, what the heck is she talking about, mechanical CPR? But yeah, I just wanted to kind of show you guys what it looked like. A lot of people, when I show videos on mechanical CPR, they're like, oh my gosh, that's so deep, that's so aggressive, but these devices, this device in particular, provides CPR at a 2-inch depth. And so this is what 2 inches looks like. So if you, again, want to just view that, you can easily find videos on YouTube that show you, what a 2-inch depth looks like. And we're not hitting it a lot of times in resuscitation. So this is just a picture in a cath lab showing a cardiologist, and I've shown this picture to some of you guys before, but so a cardiologist in a cath lab, the patient is in V-fib arrest getting mechanical CPR, so this is the device, and then you can see the cardiologist is accessing the groin, performing PCI, so stent placement, while the patient is getting mechanical CPR. And so it can easily be done. So this can easily be done in cath labs. Now, one of the questions, so this is kind of just a little joke for you guys, but one of the questions I get, this part is not a joke, is I'll get questions from people saying, you know, is this patient providing their own CPR? Like, you know, are they doing the CPR? Are they pushing a device? And the answer to that is no. The patient's not giving their own CPR. What you can do is you can strap the patient's arms up on these devices. So, like for example, in a cath lab, their arms aren't contaminating the sterile field. So anyway, I'm just going to clarify that no, the patient does not do their own CPR. This is actually a piston type device that provides compressions at a perfect 2-inch depth. So, all right, so what does the data show? So let's kind of dig into the data and ask what the data shows surrounding mechanical CPR. So there have been 2 big studies published evaluating mechanical CPR versus manual CPR. And the study I'm going to go through right now was called the LINC trial. The other study is called the Paramedic trial. But the LINC trial enrolled over 2,500 patients. So this was done throughout Europe. So it's 4 Swedish, 1 Dutch, 1 British EMS system. And what they did was they randomized patients to either get the Lucas device, which is one of the mechanical CPR devices, or to get mechanical CPR. And then they looked at 4 hours survival and then follow up at various intervals all the way up to 6 months. And so what did they find? So when they were comparing the Lucas device to manual CPR, what did they find? And when they looked at 4-hour survival in ROSC, there was no statistical differences between the groups. When they looked at survival to discharge from the ICU with good neurologic outcome, and survival to hospital discharge with good neurologic outcome, again, there was no statistical difference. 1 month survival, 6 month survival, no statistical difference. So you might be asking, well, Nicole, like, why are you even bothering doing this webinar then if there's no statistical difference? Well, I think one of the things that's really challenging when you do studies like this is that we may never get a positive study, and here's why. There's a lot of bias that's introduced into these studies, and I want you to think about this. So if you're randomizing patients to get either mechanical CPR or to get manual CPR, first of all, there's no way to blind the treatment and control groups. So there's no way to blind. So the end users are always going to know what therapy the patients are getting. The other kind of issue, and again, I think reason and that introduces bias into these studies is, especially in this LINC trial, they measured the manual CPR quality. And I want you to think about this. If you are in a study, let's say you're a medic or a nurse, whatever, if you're in a study and you are performing manual CPR as kind of the control, and you know someone's monitoring your CPR quality, how are you going to perform? And the answer is better. If you know somebody's looking at the way you perform, you're going to perform better. And so, unfortunately, that's one of the real issues in ever demonstrating a positive study with mechanical CPR, is there's no way to blind it. And if you know you're in the manual group, you know your manual CPR is being monitored, you're going to perform a lot better than you normally would. And so, again, super challenging to get, you know, really good data in these types of studies. So let's kind of look at other things they found from the LINC trial. So one of the things they looked at was neurologic outcomes and survival between the mechanical CPR, so the L CPR down here, that's the Lucas group, versus M is manual CPR group. And you can see there was a bit higher survival in the Lucas group. They had better hospital discharge. They had higher survival at 1 month, and they had higher survival at 6 months, but just unfortunately, they did not reach statistical significance. So one of the things I took away from this is mechanical CPR wasn't harmful, and it performed a little bit better, so as far as outcomes, but it definitely wasn't harmful. So that was kind of gave me some peace of mind, just knowing that it wasn't harmful compared to manual CPR. Other things, I'm looking specifically at neurologic outcomes, and you can see good neurologic outcomes were definitely higher in the mechanical CPR group versus the manual CPR, but again, just was not statistically significant. So I don't know, I'm not ready to kind of, I think there's still a lot of promise in mechanical CPR. I honestly don't know that we're ever going to get a huge positive study because of all the bias that's introduced in research. So again, one of the major limitations. So the LINC conclusions were that the Lucas device created similar short and long-term outcomes compared to high-quality manual CPR, and there were good neurologic outcomes in the majority of both groups, but again, it was slightly higher in the mechanical CPR group, not statistically significant. But so why isn't the evidence overwhelmingly supportive? And again, it's all of those things I mentioned, bias introduced, no way to blind the groups. And one of the studies, so the other study who I didn't talk about was the Paramedic study. They didn't measure the manual CPR at all. So one of the things you have to remember is in both groups, mechanical CPR and manual CPR, both of them got some manual CPR. So even the mechanical CPR group got manual CPR, and it was unclear for how long they got manual CPR. So again, that's one of the major limitations, is if the patients are getting manual CPR before you get the mechanical device on, what if that manual CPR wasn't very high quality and wasn't very good? So that's, again, another big limitation. The other thing they didn't measure was how long it took them to get the device on. This is a major sticking point. You've got to be able to very effectively and efficiently get these devices on, and so that's another one of the major limitations. And then the other thing was, the training on the mechanical CPR device was done prior to the study and then only yearly after that. So, maybe more frequent education on the device would have been helpful as well. So, again, just lots of limitations. But there's a lot of EMS systems they've definitely bought into mechanical CPR. And so what's happening across the country now is that out in the field, in some EMS agencies, after about 1 to 3 shocks, if they cannot get the patient out of VFib, they will apply the mechanical CPR devices and transport patients to hospitals. And so I will say not everyone is doing that, but there is this movement to start applying the mechanical CPR devices early and getting patients transported to hospitals. Now, one of the things that has to happen then is if you're going to transport to a hospital, the hospital has got to be ready and willing to consider taking these patients to the Cath Lab. So that's kind of a big transition that's happening right now across the country. So I would say stay tuned. There are some really smart people who are working on breaking down barriers to taking patients to the Cath Lab who are in VFib. One of the big barriers right now of taking a patient who's in cardiac arrest to the Cath Lab is that a lot of areas have to publicly report their Cath Lab outcomes. And I want you to think about this. If a patient walks in with a STEMI and gets a stent versus come in CPR in progress to get a stent, who's going to have worse outcomes? Well, it's going to be the patient who's in cardiac arrest. And unfortunately, these are reported in the same denominator. So there is some high-level discussions happening to see if we can pull these patients who are in cardiac arrest out of public reporting numbers. And I think that will remove a lot of barriers to considering to take these patients to the Cath Lab. So again, stay tuned. I think more to come on that one. So all right, so let's keep going here. So does mechanical CPR applied early make a difference? And this is kind of a cool study. It was called the MECA trial. MECA stood for mechanical cardiopulmonary resuscitation versus standard mechanical CPR and out-of-hospital cardiac arrest by emergency ambulance crews. So called the MECA trial. And what they did was, again, this was a randomized control trial where they used the Lucas device versus mechanical CPR. And so one group got manual CPR. Another group got mechanical CPR, the Lucas, but they applied it early. And so they tried to apply it after the first few shocks in the cardiac arrest. And then the third group was the late Lucas device application, where they applied the device as they were getting ready to transport the patient. So load them up in an ambulance and transport them to a hospital. So what did they find? Well, they had much higher levels of return of spontaneous circulation in the group that had the Lucas device applied early. they had more patients alive at 24 hours if they got the LINC applied early. They had more patients alive at discharge if the LINC was applied early. And then at 30 days, it was statistically significant. They had more patients alive if the LINC was applied early. And I think one of the things you have to be really careful about when looking at data is understanding when was the device applied. Because if you've got somebody who's been getting mechanical CPR for 30 plus minutes, or let's just say 10 plus minutes, 15 plus minutes, and you apply a mechanical CPR device late, you can't expect magic out of this device that was used as a last-ditch effort intervention. And so if you're going to use the device, you probably should apply it early and not, use it as a last-ditch effort. Because again, if it's last-ditch effort, everyone's going to be saying, oh, I knew that didn't work, and it becomes kind of a self-fulfilling prophecy. So I think it definitely needs to be applied early. Now, this was another study that was just published last year asking the question, is mechanical CPR or manual CPR, any form of CPR, is it safe? And what they did was they looked at manual CPR versus the LINC device versus the autopulse and asked the question, what are we seeing as far as complications? And so in general, what they found, sorry, let me go back to this, is you can see serious or life-threatening damage. The better manual had the least kind of life-threatening damage, but it was pretty close with LINC. So LINC and manual CPR probably had this best safety profiles. When you looked at different groups, again, LINC and manual had the better safety profiles. But, when you look at some of these complications that patients experienced, you have to wonder, were they putting the device in the right spot? So, for example, a liver rupture. To me, that says you didn't put this device in the right place. So, I don't know, and I think that's one of the things I took away from this study was that, you've really got to make sure placement is done as it should be over the patient's sternum and not too low. Because if you place these, these devices too low, you will see complications. Regardless of the type of CPR that was provided, rib fractures were seen. And so we all know, we've all done manual CPR and we've seen rib fractures, but you can, obviously with mechanical CPR, you'll see them as well. So, so from a safety profile and perspective, manual and LINC CPR had some of the least amount of complications. Okay, so now what about Cath Lab Experience with mechanical CPR? So this was a retrospective analysis that was published just last year evaluating 43 patients who were in cardiac arrest in the Cath Lab. 12 of them received manual CPR and 31 mechanical CPR. And what they were able to demonstrate is 74% of patients who received mechanical CPR achieved ROSC, or return of spontaneous circulation, versus 42% in the manual CPR group. So that was kind of impressive. And then again, this is just looking at manual CPR outcomes versus mechanical CPR, and you can see definitely higher ROSC rates in mechanical CPR. They had a higher survival to discharge, and then much higher 30-day survival when mechanical CPR was used. So kind of so promising. And then this was a hospital that was doing ECPR, or extracorporeal cardiopulmonary resuscitation. And really, I've spoken with the physician who leads this effort, and they really feel that if you're going to do ECPR, which is kind of the combination of ECMO, taking patients to the Cath Lab, doing PCI, and cooling them, that you have to use mechanical CPR. So a lot of them, especially after looking at this data, are feeling that there's really no way you can do ECPR without doing mechanical CPR with it. So, and that's been kind of a trend across the country. And facilities that are doing ECPR, almost all of them are using mechanical CPR as well. So kind of an interesting finding. Again, this was, I would consider lower level. This was just reporting observational data, but I think interesting nonetheless. So, all right, we're going to keep going here. This is just a Kaplan-Meier curve from that observational study, just showing much higher survival in the groups that got mechanical CPR. So you can see the group that got manual CPR had terrible survival, but they also died really quick. So mechanical CPR, you can see every time there's a drop-off, that means that's a patient who died. So, but much higher survival when mechanical CPR was used. Now, this is another study published about a year and a half ago, and this was a meta-analysis on in-hospital mechanical CPR. And I was really happy to see this because a lot of times the data that we get are from the pre-hospital setting. So this was kind of exciting to see something from in-hospital, but it was a meta-analysis where they combined 8 observational and randomized control trials. So again, this would be considered low quality of evidence, but it's really challenging, especially in hospital, to get big randomized control trials. But what they were able to demonstrate by this meta-analysis is that overall it was definitely favorable to use mechanical CPR. So I'm trying to show the highlight here. So you can see this is what's called a forest plot. And if the dots and what we call whiskers fall to the right, that favors mechanical CPR. If they fall to the left, that favors manual CPR. And so you can see, and then if it crosses this kind of what we call midline, that means it's not statistically significant. So you can see here, overall, there was definitely favorable, it was favorable for mechanical CPR. So what I'm going to show you again, what I was doing here was I asked the group, this was at NTI 2 weeks ago, is I asked the group to do a demonstration on how you would apply the mechanical CPR device in a patient who's in a bed. So we had a stretcher here, but what we did was we log rolled the patient to the side, placed the board behind the patient's chest, and then placed the device. You could see the off chest time was actually pretty minimal when mechanical CPR was used. So I would say definitely if you're interested in this, go back and watch this video again in real time, because it really shows that you can very efficiently place these devices, but it's got to be practiced, and that's kind of a key thing, is you've got to practice putting these devices on. So many of you might have tuned in to the webinars that I've done on CPR report cards. So that was the one that I did just a couple months ago. But this is a CPR report card where they're using mechanical CPR, and I can tell it's mechanical CPR because you get kind of this double hump in the impedance signal. So remember, the green is the impedance signal that comes from the defibrillator pads. But one of the really cool things is that you can just pause the mechanical CPR device really quickly, just see, do I have a shockable rhythm, yes or no? And then what you can see here is while the CPR device was going, they charged the defibrillator, and they actually shocked the patient while the CPR was being performed. Now there's a little blanking period here, but what happened was the CPR device, the mechanical device, the Lucas that they were using, kept pumping while the shock was delivered. So that's kind of a cool thing, is you can actually deliver a defibrillation while CPR is being provided. So, so pretty cool that you're able to do that. So, because one of the big issues in hospitals and EMS systems is that we have a lot of pauses around defibrillation. So here's actually an example of that. So you can see the mechanical CPR device is in use, and then what happens is they stop the device, they pause the device, they see that they've got a shockable rhythm, and I'm just going to be honest, I'm just going to say it, they take way too long here to to assess this rhythm. And then you can see they charge the defibrillator, and then they deliver the shock, and then they get right, they restart the device pretty quickly. But what they could have done is just right up here at the top, just took a quick pause, saw that there was VFib, restarted the device, charged the defibrillator while the device is going, and they could have delivered the charge while the device was going. So, those are things you learn, again, as you look at your data and understand that you can make improvements. So this is an example of a patient who was, again, they were receiving mechanical CPR, and I can tell this by that double hump, but you can see capnography. So this is when they first deployed the device, and the capnography when they first deployed the device was reading about 20, and then after a few minutes, the capnography literally went through the roof, and they got ROSC on this patient. So you can see the capno quickly elevated to over 50 millimeters of mercury, and then they were able to achieve ROSC in the patient. So, and I'll tell you, one of the things that we're seeing a lot of times when mechanical CPR is being used is we definitely are seeing, we're definitely seeing higher end-tidal CO2s. We're seeing, this is the scary thing, is we're seeing patients wake up. And so this is a new challenge that a lot of us are facing, is that with high-performance CPR, patients are waking up during their arrest. And yesterday, CNN ran a big article about a guy who was, waking up during his resuscitation. He was getting high-performance CPR, and he kept waking up. And then because he was waking up, they would stop. And then when they stopped, he was out because he was in VFib. And so they'd get back on his chest, and every time they got back on his chest, he'd wake up. And we have definitely seen this clinically. And one of the things I would say is, if you've got an IV, you've got to sedate these patients. You've got to give them sedation if they're waking up, because, we don't want patients to be awake during CPR. If they do survive, there is a lot of post-traumatic stress that can go with that, or PTSD. So, definitely what's happening now is a lot of facilities are actually starting sedation protocols because patients are waking up. So what I'm going to do now is kind of close with the idea, can we use mechanical CPR as a bridge? And so many of you have tuned in to previous webinars where I've talked about this whole idea of, what should be the endpoint of a VFib arrest. And a lot of people feel that the endpoint of a VFib arrest should be in the cath lab, artery open, because many of these patients, the cause of a VFib arrest is an occluded coronary artery. And so this was a patient, a 56-year-old, who had an out-of-hospital cardiac arrest. They got the patient to the hospital, and he was one of those guys who they were doing CPR, they got him back, they lost him, they got him back and lost him. So during one of the return of spontaneous circulation points, this was the 12-lead ECG they got. And so would anyone take this patient to the cath lab? And it's a really hard call to make, because this patient has got they've got a bundle branch block. And so it's really challenging to make that call. But in general, if you've got somebody with a suspected acute coronary syndrome and they've got a bundle branch block, we always say that they're guilty until proven innocent. So, so this patient was taken to the cath lab. And what you can see up here is the patient has a big LAD occlusion. So I'm going to go ahead and just play this video again. But they've got a big LAD occlusion. So the patient's getting mechanical CPR. So this device down here at the bottom is the Lucas device performing CPR while they're actually cathing the patient. And you can see a big LAD occlusion. And so the patient had rearrested again in the cath lab, and they were providing CPR. So then what happened was the cardiologist deployed a stent to the patient's left anterior descending, got nice flow reestablished to that LAD, and they were able to successfully shock the patient out of VFib. And you can see here that CPR, the Lucas device, is not moving because they were able to get return of spontaneous circulation in this patient. So very exciting, and these are things that we're seeing clinically in patients, that we're taking to the cath lab. So this is just a video demonstrating that the patient's getting mechanical CPR, and they're able to successfully run a wire and successfully cath this patient. So this can be done in the cath lab, and a lot of cardiologists have been, just sharing cases to show that, you can successfully cath and do PCI or deploy stents while patients are receiving mechanical CPR. And again, this is just another video showing, you can see over here on the left, mechanical CPR, and they're wiring the coronary artery and deploying a stent while mechanical CPR is being provided. So we do know that this can be done in the cath lab. So, but you've got to, again, there's a lot of comfort to get over. But this is the video on the left. You can see what's happening there is the patient's getting mechanical CPR while they're deploying the stent, and then this is just kind of showing post-stent reperfusion to the patient's coronary artery. So pretty cool stuff. So what's happening around the world? Well, a lot of cities, Paris being one of them, are having teams of physicians and EMS providers responding to patients out in the field with cardiac arrest. They're doing mechanical CPR and deploying ECMO out in the field. And so this is, I've shown you guys this picture before if you've tuned in on previous webinars, but this is a picture from the Louvre Museum, and you can see all the expensive $1 million artwork well, in the meantime, in the middle of the floor, they've got a patient who's had a cardiac arrest. They've deployed mechanical CPR, so they're getting mechanical while they're deploying ECMO, actually in the Louvre Museum. And so just a reminder for some of you who have not seen the webinar I did previously, but ECMO stands for extracorporeal membrane oxygenation. But basically, they place an arterial and venous line or cannula, and what they do is they'll pull, while they're getting, so imagine they're getting mechanical CPR, is they'll pull blood out on the venous side, run it through a pump, run it through an oxygenator, and then return it on the arterial side. And so this is basically like portable cardiopulmonary bypass that's I don't want to say it's easy to deploy in the pre-hospital setting, but it's being successfully done. And so in a lot of cities across Europe, I'll show you a picture in just a second, but they've got these teams of people who actually respond to resuscitations and assess if the patient will be a candidate for eCPR. But there's a couple ongoing studies that are super exciting. There's one out of Prague that's called the hyper-invasive study, and what they're doing is they're assessing this whole idea of using mechanical CPR, intra-arrest hypothermia, ECMO, and taking patients to the Cath Lab, and they're going to enroll 200 to 300 patients with a 6-month primary endpoint of survival. So they're going to ask, long-term, does this combination of therapies make a difference, especially in out-of-hospital cardiac arrest? And then the CHAIR trial is, again, another group that have been reporting outcomes on the idea, again, of mechanical CPR, hypothermia, ECMO, and Cath Lab. They've published early outcome data, and I would say stay tuned to see what else this study group is able to show and demonstrate in the future. So stay tuned. Again, I think we're just busting this whole world wide open using mechanical CPR and ECMO in the pre-hospital setting. So stay tuned, and I'll definitely do some follow-up and let you guys know what this is showing. But the preliminary results from the CHAIR trial, again, this was mechanical CPR with ECMO, PCI, and hypothermia, were very, very promising. And so you can see they got ROSC in 25 out of 26 patients. So 96% of patients got ROSC, or return of spontaneous circulation. 54% had experienced survival to discharge, which is super exciting. And then survival with favorable neurologic outcome with over half of patients. So this is really, really exciting stuff, and information that's coming out. So again, 54%, some of you might be saying, well, that's not very good. You have to remember the survival beforehand was 0 because we didn't do heroics to bring these patients back. So this is actually really, really promising data. So here's just kind of a fun group of pictures. So can ECMO come to you? So we know ambulances carry mechanical CPR often, but can an ambulance or a car come to you with an ECMO device where basically we can put you on cardiopulmonary bypass out in the field? And so this is a picture of the small mechanical ECMO devices. You can see they are so very small, and so skilled providers definitely can place these devices just about anywhere. So with that, I'm going to wrap up, and I'm going to hand it back over to Kim. But bottom line, what does AHA and the International Liaison Committee on Resuscitation say about mechanical CPR? They say it's reasonable. It's reasonable to use if you've got properly trained personnel, that it's reasonable to be used in specific settings where the delivery of high-quality CPR is challenging or dangerous. So dangerous would be in the back of a moving ambulance while you're transporting a patient. But challenging would be all those situations I discussed earlier. And then for eCPR, they give it a 2B recommendation saying that it's reasonable to consider in refractory cardiac arrest when you think you can reverse the cause. And again, in a lot of VFib arrest, the cause is an occluded coronary artery, and that definitely can be reversed. So in conclusion, high quality or high performance CPR and early defibrillation matter. Manual CPR is extremely challenging to provide in hospitals and in a lot of EMS agencies. So, is it reasonable to consider mechanical CPR? I would say yes, but here's the thing, is you have got to train your staff on how to apply these devices. So a lot of you have asked for my information, so I want to just kind of put this all here. My email, if you want any follow-up, my email's here. I'm on social media, so Facebook and Instagram. I've got a podcast that Physio Control sponsors called Resus 10, where I have gotten to interview some amazing resuscitation experts across the country, and we talk about just resuscitation and kind of just in general. So super exciting. So the podcast is called Resus 10. So with that, I am going to hand it back over to Kim, our moderator, and we are going to take questions at this point.
Awesome presentation, Nicole. Thank you so much. We've got a lot of great questions out there. Before we get started on those questions, I just kind of want to remind people about the continuing education for nurses and respiratory therapists. This activity has been approved for 1 contact hour of the RCE and CNE by the AARC and the California Board of Nursing, the Florida Board of Nursing. Go ahead and go to www.saxtesting.com/SL. You'll need to register on the test site and then complete the evaluation form. And then once you've submitted it successfully, you'll be able to print out your certificate upon completion. The accreditation statements are as below, as you can see. This was sponsored by Physio Control, now part of Stryker. Before we get started, I'm going to, again, thank Nicole, thank Physio Control and Stryker for these awesome opportunities. And we've got some really great questions here. So the first question I'm going to ask is from Tim. Tim says to Nicole, you talked about the Lucas as part of the study, but have there been studies that have used other compression devices?
Yeah, no, there have been. So the other device is the AutoPulse, and then there's some older devices. And one of the things that drives me nuts is when I hear people say the thumper. So the thumper is a very, very, very old device that you'll hear people reference that we don't use clinically anymore. And unfortunately, that's what a lot of people's experience with mechanical CPR is, and a lot of people didn't have positive experiences, and so I think a lot of people have been kind of reticent to using mechanical CPR for that reason. But yeah, there are. My experience is all with the piston device that delivers CPR, which mimics manual, and so that's what I mostly focused on. But there have been other studies as well, and again, none of the studies have been overly positive for any of the devices because of all the limitations that I mentioned. So yes, so that answer to that is yes.
Great. Lawrence asked about any outcomes within the pediatric population.
No, in fact, I know the device I showed you can't use with peds. So I would say, it'd be interesting to see in the future if these device companies decide to, kind of make a pediatric device. But right now, no. Not that I know of. I mean, no.
I think from my perspective, it would be really hard to incorporate a device that would fit all of the peds population, just because they're so different in growth and development, whereas adults, your CPR standards are the same.
Yeah, and I mean, and here's the reality, the definition of peds, as far as age. I mean, there's some 8-year-olds who are as big as I am. I'm 5'2", right? So there are some 8-year-olds that are as big as I am. I just don't know of any data of people using these devices on kids per se.
Yeah, I agree. I haven't seen anything either. So I apologize if I butcher this person's name. Maiken is asking to describe recommendations and options for CPR for or on patients with open chest.
Ooh, yeah, so this would not be the device. Don't do that. So sorry, because I mean, he's absolutely right. That's a really good point, is you cannot use these devices on patients with open chest or unstable sternum. So I mean, we do manual or massage. So in cardiac surgery, it's usually open chest massage is what we'll go to and fall back on. So one of the things, if you work in open heart surgery, one of the things you might consider looking at is what's called the CALS protocol, and that stands for Cardiac Surgery Advanced Life Support. And if you, and I think it's okay to make a plug for this, but if you go on Amazon, there's a book specifically for CALS that was written by a physician out of the UK, and actually Jill Lay, who's a nurse in San Francisco, but it's about the CALS protocol. But that would be an internal massage that you would do, not external CPR or chest compressions.
Yes, and I can also speak to this because I am a CT surgery nurse. Yes, CALS is this fantastic opportunity that hasn't quite been endorsed by the American Heart Association, but it's definitely heading there. And it's just this extra component of ACLS that is catered towards the CT surgery open heart population. And it's really, catering towards these hearts that are recovering and angry, and maybe the traditional ACLS is too aggressive for them. So it is taking different standards into play. I have two fantastic questions for you. One is by Jamie. They ask, after viewing the photo of the Lucas applied to a patient, the arms were attached to the device. What is the purpose of attaching the arms to the device?
Yeah, well, I mean, part of it is just to get the arms out of the way, right? So that would be one reason. You don't want to cause damage to the patient's arms, dislocation of shoulders, things like that. But also, like in the cath lab, just so that you don't have an arm, flinging around in the sterile field would be the other reason. So yeah, I mean, I think it's part of it's for patient protection, to protect their arms, but also so that their arms just aren't getting in the way.
I would agree. Yeah, I mean, it's just one way to kind of keep everything out of the way, and it's, the arm, you don't want to pinch somebody's arm. Gail is also asking a fantastic question. Does the mechanical CPR integrate the delivery of ventilation as well, and are the devices pneumatic?
Yeah, so the device that I have the most experience with, they just came out with a new one that's got some really cool settings. So you can actually alter the rate. So it used to default to 102, and now you can actually make program it to go a little faster, but no more than 120. But it also gives you a signal of when to ventilate. So you have a couple options, and it'll give you a signal of when to ventilate. So that's a great question. And so the device that I'm most familiar with is a piston-based delivery of compression. So it most mimics manual CPR. The device works on battery, and so you no longer need to hook them to air, because I think the original devices you had to hook to like an air outlet, where now they're all completely battery piston delivery of the compression.
All right, Destin has a question. Is cost the factor in what is prohibiting more use of the Lucas device?
I mean, it could be, and I can't say what the cost is, because I don't sell the device, and I don't work for any of the companies that make them. But I mean, it could be. I mean, bringing any technology into a hospital or EMS system, cost is always going to has to be a consideration. But one of the things you can think about, like if you're trying to make an argument, is if you're trying to make an argument to bring in the device, is know your data. So first of all, know your data and just know, like, do we have issues surrounding performance? So that would be one thing. But the other thing I would say, if you're trying to make kind of an argument for bringing in a device, is talk to your group. Why am I blanking on the name of the group that tracks staff injuries, and see if there are any staff injuries related to CPR delivery? Because I will tell you, it is not uncommon for nurses, techs, RTs to hurt themselves while providing manual CPR. So that would be, just from a cost perspective, a way to kind of just build the case for bringing in mechanical CPR.
I think that's a good perspective, only because you think about how absolutely physically demanding it is.
Yeah, it is.
Do manual CPR.
It is.
And you think about all this debriefing afterwards. Well, it's not only mental and emotional debriefing, but it's also physical debriefing, because people are coming away short of breath trying to resuscitate these patients.
You get a good workout, that's for sure.
That's for sure.
Yeah.
David has a question regarding rural or inner city. He feels like he doesn't think you can base this on any rural capabilities because cath labs aren't available. Is this Lucas concept based only in inner city?
No, yeah, okay, so the whole idea of eCPR definitely is the reality, so here's the reality, is if to be considered for eCPR, you've got to be close to a facility that provides ECMO and has a cath lab. So that's just a reality. But I want you to think about this, because I love his question. So the question is, could a rural area use this? And the answer is absolutely, because what do you do with patients? You transport them. And so could you transport a patient on mechanical CPR to a cath lab? And the answer is yes, absolutely. And so is it a new way of thinking? Yes, absolutely. But, there are states where they are starting to do this. I would say keep your eye on Minnesota. Minnesota is doing some really cool stuff right now. And then, of course, France and Singapore. But in rural areas, and it all depends. If you've got a transport time of like 3 hours, that's probably too long. Let's just be honest. But if you can get a patient to a cath lab in 90 minutes by airlift transporting, of course you should consider it.
Absolutely. Faye has a question of, some of our elderly are petite and small framed.
Yes, they are.
Yes, they are. Tiny little bird, sweet little elderly.
That's my goal. That's my goal at the end of my life.
To be the cute, sweet old lady.
Little bird who gets pleasantly confused at night.
Pleasantly confused. Let's hone in on the keyword pleasant.
Yes.
Would the Lucas be beneficial for those people? She can see the obese being beneficial, but the elderly that essentially have a kid's body structure.
Yeah, I mean, do we have data specifically on that group of patients? No, but let's just be honest. You're going to break ribs on that group no matter what, whether you do manual CPR or you do mechanical CPR. And then, again, this webinar is not focused on my next thing I'm going to say, but again, in America especially, asking the question, what do people really want who are elderly at the end of their life, and is CPR something they truly want at the end of their life? And I just think we have so much room in the United States to really address end of life, and is this what somebody wants? So to answer the question, we don't know. We don't have data, but are we likely breaking ribs with it? Yes. Are we breaking ribs with manual CPR? Yes. So I don't know. I don't know what to say.
I think from that standpoint, Nicole, we have to do CPR no matter what. So whether we break ribs or we don't break ribs, we could open up a Pandora's box on end of life and quality of life and what that means. I mean, that could be another 3-hour talk here. But
not today.
Not today. No. So one last question before we sign off is from Maria.
Okay.
And she asked what the difference is of delivering CPR versus to a status post-CABG patients. And really just she's focusing on a couple of months versus years post-surgery, if there's any benefit to it.
So the question one more time was what? It was...
What is the difference of delivering CPR to a status post-CABG patient and focusing on a couple of months versus a couple of years post-surgery? I guess maybe looking at like long-term.
Let's just be honest. In most things we do in medicine, we don't have good long-term data. I will safely say we don't have good long-term data. I don't know.
I would agree to that. We don't have good long-term data that focuses on what the outcomes are in regards to that. Most of our resuscitation efforts are focused on getting that ROSC back.
Well, and we're lucky to get 30-day survival. We're really lucky. Because I want you to think one of the things that's really challenging is patient follow-up, right? And so it is very expensive to track these patients down. It takes a lot of resources, and I think just in general in medicine, that's been one of the huge challenges in long-term follow-up. It is so onerous and just requires a ridiculous amount of resource to do that. So unfortunately, we just don't have a lot of long-term data. So great questions though, Kim.
Yeah, great questions, everyone. I'm going to send it back over to Emily because we are done with our questions.
I'd like to thank you very much for your time, both Nicole for this very informative presentation, and as well to you, Kimberly, for being our moderator today. It has been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.